A hiccup is an abrupt contraction of the inspiratory muscles, repeating several times per minute. The resultant rush of air into the lungs causes the glottis to close, creating a characteristic sound. Hiccups can be classified into acute hiccups last for minutes to hours and are usually benign and self-limiting, lasting for less than 48 hours. Persistent, chronic hiccups last for more than 48 hours or occur in recurrent attacks. Intractable hiccups last for more than 1 month. Benign hiccups can be caused by gastric distension from aerophagia, excessive food and alcohol consumption, and drinking carbonated beverages. Irritants to the gastrointestinal, GI, or pulmonary tract, such as spicy food or smoking. Sudden changes in ambient or GI temperature caused by cold showers or hot or cold beverages. Sudden excitement. Emotional stress and anxiety. Persistent hiccups can be caused by irritation of the diaphragmatic, phrenic, and vagus nerves. Underlying causes of vagus nerve irritation can result from pathologies which interfere with its function at any point along the length of the nerve. This is a long list of possible differential diagnoses, which include a foreign body irritating the tympanic membrane, pharyngitis, laryngitis, goiter or neck cyst, pneumonia, empyema, bronchitis, asthma, pleuritis, esophagitis, aortic aneurysm, tuberculosis, lung cancer, cor pulmonale, mediastinitis, gastric atony, gastric cancer, gastritis, duodenal ulcer, pancreatitis, pancreatic cancer, intra-abdominal abscess, bowel obstruction, cholecystitis, cholelithiasis, ulcerative colitis, Crohn's disease, gastrointestinal hemorrhage, appendicitis, hepatitis, or prostatic disease. Central nervous pathologies, including structural lesions, intracranial neoplasm, syringomelia, multiple sclerosis, ventriculoperitoneal shunt, vascular lesions, intracranial hemorrhage or infarction, arteriovenous malformation, vascular insufficiency, infection, meningitis, encephalitis, neurosyphilis, malaria, herpes zoster, epilepsy, metabolic causes, uremia, diabetes mellitus, gout, hyponatremia, hypocalcemia, hypocapnia, hypokalemia, and alkalosis. Exposure to alcohol and certain medications, such as dexamethasone, diazepam, sulfonamides, antiepileptics, dopamine agonists, and alpha-methyl-dopa. Psychogenic disorders, personality disorder, conversion reaction, hysterical neurosis, anorexia nervosa, sudden shock and grief reaction. Complications of hiccups in primary care include gastroesophageal reflux. Manometry and pH impedance monitoring have shown that hiccups can inhibit normal esophageal motility, reduce lower esophageal sphincter pressure, and alter the normal anatomy of the esophago-gastric junction, all of which favor gastroesophageal reflux. Weight loss and malnutrition, caused by persistent hiccups affecting the person's ability to eat normally. Cardiac arrhythmias, resulting from severe diaphragmatic contractions. Sleep disturbance, caused by persistent hiccups interfering with sleep. Psychological distress and reduced quality of life, caused by persistent hiccups interfering with eating, social interaction, and sleep. In a secondary care environment, hiccups may complicate mechanical ventilation, medical procedures, and can precipitate wound dehiscence. Prognosis: benign hiccups are self-limiting by their nature. They can often be averted by avoiding predisposing factors. Persistent hiccups can sometimes last for many years. Treatment of an underlying cause may lead to their cessation. Reports indicate that there can sometimes be a sudden and unexpected termination of persistent hiccups, even after diagnosis from history. From history. If the person has recurrent bouts of hiccups that persist for less than an hour, ask about exposure to potential triggers such as sudden excitement and emotional stress, sudden changes in ambient or gastrointestinal temperature, cold showers or drinking hot or cold beverages, drinking carbonated beverages, excessive food or alcohol consumption. If no clear trigger is identified and/or the person reports other symptoms or complications, use clinical judgment to determine whether a physical examination and baseline investigations are appropriate. If the person has hiccups that have persisted for longer than 48 hours, or recurrent bouts of hiccups that persist for longer than an hour, ask about duration and intensity, whether hiccups continue during sleep, This is indicative of a non-psychogenic cause. Weight loss. This may be indicative of an underlying cause or may be secondary to persistent hiccups. Symptoms that may indicate an underlying cause. Pulmonary involvement may be indicated by dyspnea, cough, sputum, and pleuritic chest pain. Gastrointestinal involvement may be indicated by abdominal pain, heartburn, vomiting, diarrhea, jaundice, dysphagia, and odynophagia. Central nervous system involvement may be indicated by seizures, peripheral sensory, and motor symptoms. Underlying malignancy may be indicated by fever, unexplained weight loss, and night sweats. Past medical medication history, paying particular attention to conditions that may affect the hiccup reflex arc. Note: be aware that psychogenic disorders such as personality disorder, conversion reaction, hysterical neurosis, anorexia nervosa, sudden shock, and grief reaction can be causes of persistent hiccups. Perform a physical examination. Examine the neck for signs of trauma, nuchal rigidity, a goiter or neck cyst, cervical lymphadenopathy, or pharyngitis. Examine the auditory canals for evidence of a foreign body. Examine the throat for evidence of inflammation of the pharyngeal mucosa. Examine the respiratory system for signs of asthma, pneumonia, empyema, tuberculosis, or pleuritis. Examine the abdomen for signs of splenomegaly, hepatomegaly, abdominal aortic aneurysm. Acute abdomen may indicate cholecystitis, cholelithiasis, pancreatitis, appendicitis, intestinal obstruction, or rupture of a hollow viscus. Carry out a neurological examination to detect evidence of stroke, meningismus, encephalitis, or a space-occupying lesion. Carry out baseline investigations including full blood count. Abnormal findings include leukocytosis in inflammation or infection, and anemia in malignancy or gastrointestinal hemorrhage. Urea and electrolytes to exclude uremia, hyponatremia, hypokalemia, and hypocalcemia. Further tests indicated, some of which are performed in secondary care, include liver function tests. AST and ALT may be elevated in hepatitis, and alkaline phosphatase may be elevated in biliary obstruction. Erythrocyte sedimentation rate, or C-reactive protein level. Elevated levels suggest inflammation, infection, or malignancy. Gamma-glutamyl transferase, gamma-GT, may be elevated in biliary obstruction and chronic alcoholism. Serum amylase may be elevated in pancreatitis. Arterial blood gases may reveal alkalosis. Toxicology screen may reveal elevated blood alcohol, or positive drug screening for tetrahydrocannabinol, EDTHC, amphetamines, cocaine, sedatives, or tricyclics. Electrocardiogram may reveal evidence of ischemia, pericarditis, or electrolyte disturbances. Chest radiograph may reveal evidence of pulmonary disease, neoplasm, mediastinal lymphadenopathy, or cardiac abnormality. Pulmonary function tests may reveal an obstructive or restrictive pulmonary disorder. Abdominal CT may reveal evidence of obstruction, perforation, inflammation, abscess, neoplasm, hepatosplenomegaly, or abdominal aortic aneurysm. Endoscopy of the upper GI tract may reveal evidence of esophagitis, esophageal cancer, duodenal ulcer, or gastritis. Head CT or MRI may reveal evidence of a space-occupying lesion, inflammation, hemorrhage, or infarction. Lumbar puncture may reveal elevated protein, decreased glucose, leukocytes, bacteria, or xanthochromic liquor. I manage a person with hiccups. For people with hiccups, any duration, advise them to avoid any identified trigger factors. Where possible, suggest the use of self-help remedies during a bout of hiccups, such as breath holding, the Valsalva maneuver, a forced expiration against a closed glottis, breathing into a paper bag, pulling on the tongue, sneezing, swallowing a teaspoon of granulated sugar, tasting vinegar or biting a lemon, sipping iced water, compressing the diaphragm by pulling the knees up to the chest, swallowing water while closing the nose. For people with hiccups that have persisted for longer than 48 hours, or recurrent bouts of hiccups that persist for longer than an hour, if history, physical examination, and/or baseline investigations have suggested a probable underlying cause, either treat in primary care if appropriate, or refer to an appropriate specialist, with urgency determined by clinical judgment. If no underlying cause is identified, consider carrying out any outstanding investigations, if applicable. For people in whom an underlying cause cannot be identified, or whose hiccups persist after treatment of an identified underlying cause, advise that acupuncture, hypnosis, and/or psychotherapy can be tried. Consider utilizing techniques to interrupt the hiccup reflex arc, such as stimulation of the nasopharynx with a finger, rubber catheter, or cotton-tipped applicator, lifting the uvula, or inducing a gasp by smelling salts or other noxious agents. Consider specialist referral so that pharmacotherapy can be initiated. Drug treatments include chlorpromazine. This is the recommended treatment. It is initially given intravenously, and if it proves successful, can be continued orally for 7 to 10 days. Metoclopramide, off-label use. This is given intravenously for a maximum of 5 days. Other drug options include quinidine sulfate, phenytoin, valproic acid, baclofen, haloperidol, nifedipine, gabapentin, and sertraline. Carbon dioxide, 5%, is also sometimes utilized. If hiccups persist despite all of these measures and are associated with significant discomfort and morbidity, consider specialist referral for disruption of the phrenic nerve. Follow up the person at an interval determined by clinical judgment. Advise them to report any signs of complications such as cardiac arrhythmias, insomnia, weight loss, and esophagitis. How should I manage someone with hiccups in a palliative situation? Recommended approaches include antiflatulence, or for reflux disease, peppermint water, antacid medication or proton pump inhibitor such as omeprazole, prokinetic, domperidone, or metoclopramide. In a palliative care situation, where hiccups are known to be a complication of cancer, specialist referral for pharmacotherapy or other measures to control hiccups may not be appropriate, and it may be necessary to seek advice from a palliative care specialist. Dexamethasone, 4-8 milligrams oral in the morning, may reduce compression irritation if the patient has either hepatic, mediastinal, or cerebral tumor. It should be stopped if no benefit is seen after 1 week. Other possible recommendations from a specialist may include haloperidol, oral micrograms to 1 milligram every hours, maintenance doses 3 milligrams at bedtime, baclofen 20 milligrams 8 hourly if required. Avoid abrupt withdrawal. Levomepromazine, oral 3-6 milligrams dose at bedtime. Avoid if hypotensive. Nifedipine, mg, hourly if required. Avoid if hypotensive.